And we have our next speaker, Dr.Jambunathan Ramanathan, MD Diplomat, American Board of Internal Medicine, Diplomat in American Board of Infectious Disease, Faculty in Department of Medicine. He would be talking on strategies for reducing hospital redemption for heart failure patients. Sir, join us online.
Hello, good morning to all of you. This is Dr. Ramanathan from Troy, Michigan, and glad to be presenting in the GCDC conference. We'll be starting our talk on the strategies for reducing hospital admissions for heart failure. I'm just starting with a question and, just to trigger your interest. All the following strategies have been found effective in clinical studies to reduce hospital admissions for heart failure except number 1, implement strategies for screening and addressing social determinants of health. Number 2, comprehensive medical management, including adherence to guideline-directed medical therapy, addressing comorbid medical conditions, immunizations, and personalized exercise program. Number 3, structural and integrated outpatient care, such as multidisciplinary heart failure clinics, including cardiologists, internists, nurse, pharmacists, dietitian, and social workers. Provision of telemonitoring services and telephone-based care management. Number 5, comprehensive patient self-care education initiated in the hospital and continued after discharge. And finally, follow-up with outpatient with the physician in 1 week and home care visit with case management by nursing staff. So the question is, except in these 6 strategies mentioned, only 1 does not work according to the clinical studies so far done. 5 seem to work. So we have to pick up which one does not work. I'm just going to go to the next slide. And the choice number 4, provision of telemonitoring services and telephone-based care management, that is the only strategy which has not been shown to work very effectively in the clinical studies done so far. But the rest of strategies have some evidence-based to seem to work to prevent hospital readmissions for heart failure patients. With that, I want to just introduce to heart failure, the burden of heart failure. And it's a significant healthcare burden throughout the world. And it's a cause of hospitalizations and readmissions. I just have the United States data, and according to the American Heart Association, it is projected that the heart failure cost will increase from $30.7 billion to $69.7 billion by 2030, and the heart failure prevalence will increase by 46% from 2012 to 2030. And heart failure is also the highest rate of readmission at 23.5%, which means approximately 4 of the patients discharged for heart failure, 1 of them is likely to be readmitted within 30 days. And the costs associated with readmissions are substantial and contribute to additional annual spending worldwide. Thus, preventing readmissions for heart failure is a prime concern for researchers, providers, and other relevant stakeholders in the healthcare system. So this is just to give you a broad introduction to the stages of heart failure. Most of you are aware of it. This is the American Heart Association classification. Stage A is where they are at risk, which means they have risk factors for heart disease. Stage B is they have evidence of structural heart disease, but no clinical signs. Stage C is where they have mild to moderate symptoms. And stage D is where they have severe heart symptoms. So these are the stages, and actually intervention is possible in every stage, but we're going to be focusing more on stage C, where patients already have diagnosed heart failure and already they got admitted to the hospital, and we're trying to prevent readmissions for this particular group. And what are the risk factors for poor outcomes? Patients with heart failure usually have medically complex and they have multiple comorbid conditions. They're taking several medications and they have a wide range of symptoms. Some of them could be due to CHF, some of them due to comorbidities. And the natural history of heart disease is like if you don't intervene, they go through a series of decompensations and they never return to their previous quality of life, and they need more and more intensive care down the road and finally spiral to pump failure and death. And there are many health and social health factors linked to poor heart failure self-care and poor clinical outcomes. Depression is one of the foremost. Depression is a risk factor for poor self-care, rehospitalization, and all-cause mortality. Social isolation, these people, they're not part of the community because they're very inactive, and social isolation becomes prevalent, and social isolation is also a cause for rehospitalization. Frailty and inadequate health literacy, they are not very knowledgeable about their disease, so they are not very capable of doing self-care for themselves. And frailty means they're nutritionally getting more and more weak, and that also reduces their mobility and activities. Considering all the healthcare access, health literacy, and other socioeconomic factors, preventing and reducing heart failure is a much more complicated task. So other risk factors for readmission is, the main thing is like we said about the proportion of readmission that can be prevented is 27%. So I already told 1 in 4 of them get readmitted, and out of the people who are getting readmitted, how much you can really prevent? In reality, studies have shown only 1 in 4. So 1 in 4 get readmitted, and of the 1 in 4 who get readmitted, only another 1 in 4 you can prevent the readmission. And we'll go through why the reasons are. And it may be reasonable to hold hospitals for patients coming back within the first week. So let's say you discharge a patient today and they come back to the hospital with a problem within the next 5-6 days. It's usually some problem with patient education or medication reconciliation, and which is sometimes fixable. Whereas usually hospital admissions that happen after 1 week are due to multiple other factors, which could be related to the quality of outpatient care, resource available in the community, the ability of patient to provide their own self-care, or a development of a new problem. They could have come with heart failure, they go home, they get a pneumonia, and then they come back, which is not entirely preventable. So how to assess the risk factors? So you want to first assess which patients have a high risk for readmission and which patients have a low risk of readmission. And that way you can target your more energy and your investments on those people who have a high risk for readmission. And there are several readmission risk models developed. I'll show a couple of them in the next slide, but there are much more than what I'm stating, and you can use one of those validated risk readmission models, and that be able to predict whether this particular patient is going to come back or not within the next 30 days, so that you can focus your resources on them. And when you're using these models, you should always be aware of the model complexity, the data availability, and the model performance before you can use it in a large scale. So these are 2 examples, the LACE index and the RAHF scale. These are 2 just examples of the risk prediction models which can be developed, and they are mentioned even in the AHA heart guidelines. And so you can use one of this, and there are a few other things too. And you can choose one which is suitable to your system and assess the patient's readmission risk. So now coming to the actual factors which can prevent readmissions. So we talked about the risk factors, how to predict the risk for readmission, and now what are the strategies that you can employ to reduce readmissions. These are the 8 which have been shown in studies to be helpful. Implementation of guideline-directed medical therapy, that is the foremost. Enhanced remote monitoring of patients, seamless transitions of care, patient and caregiver education for better self-care, addressing social determinants of health, addressing comorbid psychiatric and medical illnesses. It's physical, that should be actually psychiatric and medical illness, multidisciplinary team care, and increase home-based support and close outpatient follow-up. So these are some of the 8 strategies which have shown to help in preventing readmissions. Out of this, the guideline-directed medical therapy is the most important, and I'll be focusing almost 50% of the talk on that. The interventions that have been shown to be most effective is in preventing 30-day readmission is the efficient use of the GDMT, guideline-directed medical therapy. And the GDMT has been updated by the American Heart Association. The latest was released earlier this year in 2022. And there are 4 drugs which have been useful to prevent hospital admissions and improve outcomes. And the latest one which has been used in the guidelines is the SGLT2 inhibitors, which we'll talk about too. And not only implementing the GDMT, but also achieving the target doses. This seems to be one of the major factors which prevents readmissions and improves outcomes for patients. So these are some of the pivotal trials which have helped us define these medications. The Paradigm HF trial compared the ARNI, which is the angiotensin receptor blocker, along with the nephrolysin inhibitor, ARNI, we call ARNI in short. Entresto, which is a combination of valsartan and sacubitril, was compared with enalapril, the standard AC inhibitor. And this Paradigm trial showed that there was a 38% lower risk of readmissions with Entresto, which is the ARNI drug, compared to enalapril. And the SHIFT trial was another trial which utilized ivabradine on patients who have persistent heart rates above 70 per minute. And this is a selective sinus node inhibitor. Adding the drug to the regimen has found to prevent readmissions. The TopCat trial was specifically designed for people with heart failure with preserved ejection fraction, we call diastolic heart failure. The TopCat trial helped to prove that spironolactone, the mineralocorticoid receptor antagonist, was effective in reducing hospital readmissions. And the recent trials, the Emperor reduced and the Emperor preserved trials, established the role of SGLT2 inhibitors, empagliflozin, in reducing hospital admissions and improving outcomes. And this trial was the one which made the SGLT2 inhibitor get into the guidelines. Diuretics are frequently used. They're useful for symptom relief, but they have not really shown to alter the natural history of the disease. And this is just a snapshot of the American Heart Guidelines, which goes through the different stages. What are the step 1, step 2, and up to step 6. The initial step is after the diagnosis, and you have diagnosed heart failure with reduced ejection fraction, which is systolic heart failure. The 4 drugs, ARNIs, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors are the more important diuretics as needed for symptom relief. And then as patients progress, you can see whether they qualify for additional drugs. If they're African Americans, they may need hydrazine nitrate. And if they're persistent low ejection fraction, they might qualify for ICD. And if they have prolonged QRS complex along with lower ejection fraction, they may qualify for the CRT device, which is the cardiac resynchronization device to improve outcomes. And finally, in patients who keep progressing, you should involve the palliative care and advanced heart failure specialists to see if they qualify for mechanical circulatory support or cardiac transplant or palliative care and hospice if their disease is much advanced. So these are kind of a snapshot of using medications and devices in heart failure patients. And the GDMT, so it's not only putting the patients on the drug. There are 2 important things. We want to make sure the patients are adherent to the drug, and you're also increasing the doses frequently to achieve the target dose. And that's what's most important. And it's important to consider the biological factors, social determinants of health, and implicit bias when you're implementing GDMT. For example, at least in the United States, the African American population, the hydralazine nitrate added to the standard drug improves outcome, but it has not been shown in other populations. So there are some biological factors which can be addressed. And then the other important thing is you should have studies which have shown that at least 50% of target dose achieved, those patients had better clinical outcomes. So the important thing is not only starting the drugs, but making sure the patient are adherent to the drugs and also trying to achieve the target dosing. And non-adherence to GDMT, what are the problems with GDMT? Sometimes some patients are non-adherent, and this could be due to both patient factors and hospital factors. Hospital factors could be like physicians at the time of discharge fail to prescribe these medications, which happen once in a while. So using pre-discharge checklists in the electronic records could be a way of preventing that, so that all patients, when you put a diagnosis of heart failure, it should make you automatically remind you to put these drugs on the discharge medications. And then interventions to improve awareness by patient education and other means. And so by implementing these adherence mechanisms, you can reduce the readmission for the patient. So this is again taken from the AHA guidelines. In patients with heart failure, titration of guideline-directed medication therapy to achieve target doses in randomized control trials reduces cardiovascular mortality and also reduces heart failure hospitalizations. And how frequently can you titrate the drugs? As frequently as 1 to 2 weeks. So let's say you start somebody on Coreg 3.125 BID, which is carvedilol. You can bounce it to 6.25 BID as tolerated every 1 week up to the target dose of 25 BID. I'm just giving one example of a drug. And what are the limitations of GDMT? So, not every patient you are capable of starting all the drugs and achieving the target dose because they have some comorbidities. For example, people who have renal dysfunction, they usually get hyperkalemia with the mineralocorticoid receptor antagonist. And so not all patients are capable of achieving these drugs. And so, and it could be medication intolerance. Somebody gets a side effect like angioedema with ARNI, you can't use them. And they have renal, some people get hypotension sometimes. And every time you titrate the drug, they get more hypotensive. So you cannot titrate the dose of the drug upwards. So these are some of the pitfalls, drug side effects, electrolyte side effects, hemodynamic side effects, those prevent in some patient populations you cannot achieve this. So it is suggested that if you have patients in that scenario where you can achieve the target dose, it is suggested you refer them to advanced heart failure therapies much earlier to improve outcomes. And again, this is achieving, addressing some of the comorbidities. For example, heart failure patients with iron deficiency anemia, giving IV iron, patients with heart failure with uncontrolled atrial fibrillation, playing AV nodal ablation and to other mechanisms to reduce the ventricular rate, and people with sleep apnea and heart failure, making them compliant with the CPAP use. All these things are, addressing the comorbidities, also help in improving the outcomes and hospitalizations for heart failure patients. And in selected patients with reduced ejection fraction, they might be candidates for coronary artery bypass grafting, the CABG suit. And so, in addition to the GDMT, you should refer them for improving their coronary perfusion. And again, this other drug which has been studied, vericiguat, which is a oral soluble guanylate cyclase stimulator. And this is one of the new drugs. And again, in patients who are already on GDMT and getting hospitalized, adding vericiguat has been shown in some studies to prevent readmissions. So ivabradine, once I mentioned the SHIFT trial for people with high heart rates and sinus rhythm, and vericiguat are the other drugs which you can add to some people's GDMT to reduce hospitalizations. The other step is monitoring for congestion, because congestion is the first thing which happens, which progresses and patients come to the hospital with worsening pulmonary edema. So if you can monitor congestions and address the congestions early, you can prevent the admissions. And the Champion trial was one of them. It kept a wireless implantable monitor in the pulmonary artery as a part of the cardiac cath procedure. And the patients went home with this, and they had a sensor at home, and through the sensor device, the information every day could be communicated to the physicians, what is the level of the pulmonary pressures, and thereby giving a rough estimate of the congestion happening. And this study, where frequently the data was transmitted to the clinicians and the clinicians acted on it, there was a 37% reduction in the heart failure. So this is something novel which is coming up, is doing home monitoring for pulmonary pressures. But as of the latest guidelines, though it seems to work, the AHA guidelines said that it would like to have more data before it can be implemented for routine care. And multidisciplinary care and self-care, heart failure should be usually provided by multidisciplinary teams, which means includes physicians, social workers, dietitians, pharmacists working in collaboration to improve patient education and self-care. And the large part of heart failure is it's a chronic disease, so the patient has to be educated well so that they can adhere to the treatments, they can limit their sodium intake, stay up to date with the vaccinations, and adherent to their medications and follow-ups. So those things are key component of CHF management. And again, this is from the AHA guidelines that patients with heart failure should receive care from multidisciplinary teams to facilitate implementation of GDMT and address other potential barriers to self-care. And patients should receive specific education, and they should be vaccinated against respiratory illnesses. And finally, you should also screen for depression, social isolation, frailty, low health literacy, all of this which I mentioned in the initial slides, which are risk factors for readmissions. You need to screen patients for them and address them early so that you can improve outcomes. And then transitioning from hospital discharge to outpatient, the transition of care. So after multidisciplinary care, transition is where the patient is going from inpatient to the outpatient setting. And this is where a lot of problems might happen, because the inpatient physician might be different from the outpatient physician, and they might not know all the things happen. And the continuity of care and communication is very important, so that when they move from one level to another level, patients can get the appropriate care. And the study was done in 2004, and the meta-analysis done in 2004 showed that comprehensive discharge plans improved outcomes. And this study predominantly used a nurse transition coach who educated patients and family before discharge. So the intervention which was studied in this transition of care studies were nursing education, which focused on medication self-management by patient, like they know how to take their drugs, what time, and how to reduce the dose in case of some side effect. A patient-owned health record, so they are aware of all the findings and things happening in their illness. And then follow up with the addressing very close follow-up in the outpatient setting. So you get discharged from the inpatient, make sure they have close outpatient follow-up and awareness of red flags, so patients know when they are deteriorating, so when they have to come back to the hospital. So when these kind of things were addressed regularly with the patient, this care transition intervention reduced hospital admissions in 30 days and 90 days, not only in studies, but also in real world studies. So educating patients about the disease and management techniques is a large component of the readmission prevention. And again, another transitional care plan involved cardiac trained nurses. They educated patients in 5 domains of the chronic illness, knowledge of the illness, relationship between medication and illness, relationship between behaviors and illness, and recognition of early signs of decompensation and how to obtain assistance. So when patients were well educated on all these 5 components, again, this was shown to reduce mortality and hospital admissions. So consistently it is shown that better the patients are educated, even by the nurses in the hospital, it improves outcomes. So, and again, another step is engaging caregiver, because some of your patients might have dementia or poor literacy and they might not be able to understand your education. So to see whether there is a family support available and the caregiver support, and educating the caregivers in those cases and empowering them also seems to help in those. So you have to assess your patient's health literacy needs as well as his social support, and involving the caregivers also might improve outcomes. And again, the teaching can be done either by the bedside nurse if she's well trained, or even by specialized heart failure nurse educators if your hospital can afford them to see these patients while they're in the hospital before they get discharged. And this is a transitional care plan. And again, this is I'm going to leave the slide with you guys so you can see this in detail. I'm not going to go step by step, but kind of outlist all the points which we are just talking about in a stepwise manner, what you can do when patients are getting discharged, what are the different steps you can follow. And this is like a bridge. You can see hospital in one end, community is the outpatient setting, and this is like a bridge which connects them. And starting from discharge planning and communicating the information to the primary care physician, and then coordinating the care among different plan team members and addressing close outpatient follow-up. So these are the different stages which you can look through, and as you address all these stages, it seems to improve the outcomes for patient, and their mortality reduces, and as well as the readmission risk also reduces. And again, this is from the AHA guidelines, patient-directed hospitalizations, which is again re-emphasizing the multidisciplinary care and patient-centered discharge instructions. So you should give instructions to patients in the language they can understand, or if the patient cannot understand, their caregivers should be able to understand. And then this important point of early follow-up within 7 days. So in our hospital, we routinely, if you have a patient with heart failure who is getting discharged, we make sure they have a 7-day appointment with their primary care physician in 1 week, even before the discharge, so the patient knows exactly when to come back to the outpatient clinic so that they can have close follow-up. And so other strategies, the outpatient follow-up, which we just talked about. So what do you do in the outpatient follow-up? We told they have to come back in 1 week. And is there any data for that? And there are studies which have shown either the patient come back to the primary care clinics, or even specialized nurse practitioners and pharmacists working together in a special clinics. And one study was done using a nurse practitioner and a pharmacist working together in an outpatient follow-up after the hospital discharge, and they followed protocols developed by a cardiologist. And in this study, patients came back at 1 and 4 weeks after the admission. And during the follow-up, all these were taken care of: physical exam, medication education, and up-titrating the doses to the target doses, and then disease education more about how to identify early symptoms, and seeing whether they need other outpatient support, like they have comorbidities, they need to see the lung doctor or something, arranging all the coordination of care, and then again discharging the patient with a good medication list, and when to come back again. So when these were all very meticulously followed in the outpatient follow-up, there was a 44% reduction in 30-day readmission. So showing that a 7-day visit with a protocol-based management of these patients seems to reduce readmissions. And social determinants of health, this is addressing their patients' economic factors, education factors, social support in the community. So because if patients are living alone and they are poorly educated, for sure when they go home, they're not going to be taking the medication, they're not going to be compliant with the diet, there's a high risk of readmissions. So, and then psychiatric illnesses, patient of anxiety, depression, schizophrenia, those are going to prevent the patient also from adhering to the medications. So addressing these factors, the psychiatric problems, substance abuse problems, and social determinants of health are other key factors to prevent readmissions. And again, I'm not going to go to the detail in this, but just to see this is addressing all the barriers. So for example, cognitive impairment, patients are cognitively impaired is a barrier for outcomes. How do you assess? You can use the mini-cog or the MMSC scale to address. So this is a screening tool, how to identify the problem. And then once you identify the problem, what are the interventions you can do, like home health aid, geriatric psychiatric referral. So same way, it goes through all the bad problems, depression, how do you identify it, what intervention you can do for it. So these are all the things in social determinants of health and mental health things which you have to address. It goes through all the steps of, the different, which are the non-medical causes of readmission. And again, low health literacy. Patients are not well educated. How do you even identify whether the patients are literate? There are scales which you can employ to assess the patient's literacy level. And then once you identify the patient's low literacy, what are the things you can do to improve their outcomes is based on all these studies. So telemonitoring is where, what do you mean by telemonitoring is there is electronic communication between the patient and the provider using phone and electronic transmission data. And this was practically intuitive. We thought, once we get this data regularly, it might improve outcomes. But so far, the studies have not shown a very robust improvement in outcomes using telemonitoring. And that's why in the first slide, I said this is one of these strategies which has not shown to be effective. Maybe if the strategies are modified down the road, we might find it to be improving. But at this point, it's not working. So the second thing that doesn't work is singular interventions. Remember, I mentioned 8 points of strategies which can improve outcomes. If you just employ 1 or 2 of these interventions, again, the outcomes don't improve. You should have a multifaceted intervention. So telemonitoring doesn't seem to work, and using singular interventions also doesn't seem to work. And then the high-risk patients, like these are the patients, despite whatever you do, they're going to be coming back to the hospital. And usually those are the ones with multiple comorbidities, poor functional status, and severe socioeconomic problems. They carry a higher risk of readmissions, and many of this may not be correctable. And so, in these cases, patients who are having multiple readmissions, it is better to involve palliative care and advanced care planning so that you can address their goals of care and whether they have to be transitioned to hospice or like when they really want to come to the hospital and can you manage them in other settings. And again, support for the caregivers. Sometimes the patient has a caregiver who's been taking care of him for 10 years. The caregiver has more problems sometimes than the patient. They have a high risk of developing depression and heart disease. So it is important to address the caregiver problems too. And again, as estimates suggest, only 1 in 4 of the readmissions are really preventable. So it's not a large thing which can accomplish. But still, if you can prevent 1 in 4 hospital admission, that's if you look at the larger scale, it reduces the cost and improves outcomes for patients. So the summary is, again, interventions that are multifaceted seems to work, like using the GDMT, medication reconciliations, appropriate transitions of care, adequate follow-up visits, enhanced communication, and educating patient about their self-care. All these things put together like multifaceted interventions, that seems to improve outcomes for these patients rather than singular interventions. And other improvement that may result from a greater focus on transitions of care, such as more efficient process of care, better teamwork, good collaboration between outpatient and inpatient teams, and improved patient satisfaction, and also addressing the quality and safety during their hospital admissions. All these can improve outcomes also. I think that's the end of the slides, I think.
Thank you, sir, for your elaborate lecture about to prevent the cardiac failure patients for readmission. You have given many guidelines and strategies. Thank you very much, sir. Thank you.
Hello?
Yeah, sir, shall I stop?
Yeah, the 20 minutes is over.
Thank you, Dr. Nagarajan sir, for chairing this session wonderfully. I also thank Dr. Luigi Nudi and Jambunathan Ramanathan for their great talk. Now it's clinical grand round in nephrology with live quiz by Professor Edwin Fernando.
Graduate and postgraduate training.